Good morning, everyone. I'm Dr. Nivedita Jahati from GMCH Nagpur, and I'm going to present about the placenta accretus spectrum, a case series, under the guidance of Dr. Humne sir. Introduction, coming to the introduction, the morbidly adherent placenta is a major cause for massive obstetrical hemorrhage, which leads to the maternal morbidity and the mortality. The most accepted hypothesis for the etiology of the placenta accretus spectrum is a defect in the endometrial myometrial interface, which leads to the failure of normal decidualization in the uterine scar, which allows the abnormal deep infiltration of the placental anchoring villi and the trophoblast. It becomes exponential and life-threatening when placenta previa is associated with placenta accreta spectrum. There are several risk factors for the placenta accreta spectrum, the most common being the previous cesarean section. The placenta accreta is a one where the abnormal villi they're attached to the myometrium. The placenta increta is the abnormal villi are invading the myometrium. The placenta accreta is abnormal villi penetrating through the myometrium or through the serosa. Clinically, the ratio of these variants is more than 70:13:5 respectively. The antenatal diagnosis of the placenta accreta is highly desirable as the outcomes are optimized when the timely delivery occurs at the tertiary care facility accustomed to handle such cases. Here, we are reporting the 6 cases of the placenta accreta spectrum managed by the conventional and the expectant way at our tertiary care hospital. Study was carried out in a government medical college and hospital, Nagpur. The different methods have been implicated in the management of placenta accreta spectrum, the ranging from uterine conservation and the conventional hysterectomy. The conventional management of the placenta accreta spectrum is the caesarean hysterectomy with the placenta left in situ after the delivery of the fetus. Expectant management of the placenta accreta spectrum involves the leaving the placenta partially or totally in situ and monitoring for the placental resorption. The case method is records of the patients with the placenta accreta syndrome between December 2021 and June 2022 were revived and analyzed. The results, 6 cases of the placenta accreta syndrome were studied. The 100% of the patients had a history of previous cesarean section. The 5 patients had associated placenta previa. 1 out of 6 patients had a history of dilatation and evacuation for the missed abortion. 4 out of 6 underwent a caesarean hysterectomy and the 2 underwent a conservative management with the uterine preservation. The average blood loss was 2.5 liter and the conservative management was successful in 2 patients and there was no maternal mortality in the case series. First case is the patient, she is a 25 years old, gravid to paravan living one, previous cesarean section, 2 years back, presented to the emergency department at 28 weeks 2 days with the complaints of painless bleeding per vagina. On admission, the patient was hemodynamically stable. USG with Doppler showed a placenta anterior and completely covering the os with the multiple venous lacunae invading the myometrium. At 30 weeks, the patient again had one more episode of bout of heavy bleeding and taken for the emergency cesarean section. The placenta was completely adhered to the uterine wall with the intact serosa. The inseparable placenta was kept in situ. The bilateral uterine, ovarian, internal iliac arteries. Ligation was done. Intraoperative blood loss was 2 liter. She received the blood and the blood products, and complete resorption of the placenta was seen at about 14 weeks post-delivery. The second case is, she is 24 years old, gravid to paravan living one with a previous cesarean section 3 years back, presented at 32 weeks of gestation with a bleeding per vagina. The patient was pale but hemodynamically stable. The prior USG at 21 weeks was suggestive of placenta low-lying with the features of placenta accreta. She received an injection tranexamic acid, steroids, and she has transfused with the 2 points of packed red cells on hemoglobin 7. The active bleeding continued. The patient was taken for the emergency cesarean section. The large venous lakes and the tortuous vessels were present over the lower uterine segment, invading the bladder base, placenta accreta present with the placental tissue invading the bladder base. While palpating the fetal pars, one of the venous lakes ruptured. The profuse bleeding was present. The rent at the venous lake was extended with the fingers, and the preterm female baby 1.9 kg was delivered. The OH obstetrical hysterectomy done. The placental tissue removed as much as possible from the bladder base after defining the bladder margins. The hemostatic sutures were taken and the pressure packing done. Hemostasis achieved and the abdomen closed in layers. The patient received the intraoperatively the multiple blood products, and she was on inotropic supports for 2 days. Post-operatively, she received a 3 whole blood and got discharged on day 21. Third patient, she is a 28 years old, gravid 3, paravan living 1, abortion 1, with a previous cesarean section 8 years back with a 39 weeks of gestation got admitted to the OPD as a referred case. On USG, the placenta was anterior with the two lobes, superior lobe showing the indistinct zone at a myometrial placental junction with the placental tissue invading the myometrium. The patient was posted for elective cesarean section, abdomen opened by the phalansteal incision. There was evidence of dilated vessels over the anterior wall. The uterus was opened by the transverse curvilinear incision. A full-term female baby 2.9 kg was delivered with the superior lobe of the placenta adhered to the myometrium. The bilateral uterine arteries were ligated, uterotonics were given, active bleeding was present still from the superior lobe of the placenta, subtotal obstetrical hysterectomy was done. Intraoperatively, there was a blood loss of 2 liters. The patient received the 2 points of blood intraoperatively and 2 points of blood and FFP postoperatively. Patient was discharged on day 10 of delivery. The fourth case is 26 years old patient, gravidated to paravan living one with a previous cesarean 2.5 years back, presented at 30 weeks 5 days of gestation with the placenta previa in bleeding phase. USG was showed the anterior placenta completely covering the os. The patient was pale, uterus 32 weeks with a cephalic presentation. The mild uterine contraction were present. On local examination, os was closed and bleeding was present. She was taken for the emergency cesarean section. Placenta anterior left lateral completely covering the os. Adhered to the myometrium, cord was tied near the placenta. Placenta kept in situ. Devascularization was done. No active bleeding was present and uterus was closed. She received multiple blood products and the complete resorption of the placenta was seen at 13 weeks post-delivery. Fifth case, she is 26 years old, female patient, previous cesarean section 5 years back, got admitted to the emergency department at 33 weeks as a placenta previa in bleeding phase. The USG, the placenta was posterior-lateral, completely covering the os. The patient was hemodynamically stable. Uterus was 34 weeks, cephalic. The uterine contractions were present. Local examination, os closed, bleeding present. And then she was taken for the emergency cesarean section. The placenta was posterior-lateral, completely covering the os, adhered to the myometrium, more on the left side. The uterotonics were given. The bilateral uterine arteries ligated. Active bleeding was present. Obstetrical hysterectomy done. And the bilateral internal iliac ligation was done. The patient received the multiple blood products and she was kept in ICU for 2 days, discharged on day 12. Sixth case, she was 24 years old with a previous cesarean section 3 years back, got admitted at 28 weeks of gestation with a diagnosis of placenta percreta. MRI findings showed the placenta completely covering the os and invading the myometrium and serosal layer. There was a loss of hypoechoic clear zone between the placenta and the myometrium, and the patient received the steroids. Conservative management was continued. Elective cesarean was done at 38 weeks of gestation. Abdomen opened by the midline incision, evidence of placenta percreta present. Bilateral internal iliac arteries were ligated, and the cord tied near the placenta. Placenta kept in situ and uterus was closed. The patient received the multiple blood products, and the single dose of injection methotrexate was given on day 5. On day 14,
Dr. Nivedita, time up. Can we come to the conclusion, please?
Yes, ma'am. The mean age of the patient was 25 years. The 5 cases presented in the emergency in bleeding phase. One was booked case and the one was admitted from 28 weeks of gestation and underwent elective LSCS at 37 weeks. All the patients had a history of previous cesarean section. One patient had a history of suction and evacuation for the missed abortion. In this case, the placenta had 2 lobes with a superior lobe showing the myometrial invasion at the fundus and the uterus. 4 patients had a previous USG finding suggestive of the placenta previa and accreta. The one had a USG, evidence of placenta previa accreta was not ruled out. Only one patient had an MRI diagnosis of placenta percreta. The 2 patients underwent elective LSAs at 39 weeks and 37 weeks. One had evidence of myometrial invasion at fundus and the cesarean hysterectomy was done. Second patient had evidence of placenta percreta intraoperatively. Placenta was left in situ. After the baby delivery, this patient required the interval peripartum hysterectomy due to the sepsis. And the conservative management was successful in 2 patients, with the placenta was left in situ in these patients. With the stepwise devascularization was done. Autolysis of the placental tissue was monitored post-operatively by the ultrasound Doppler. Complete resorption of the placenta took around 13 to 14 weeks post-delivery. One of these patients received a single dose of injection methotrexate. In 2 patients, emergency cesarean hysterectomy was done. One had a placenta accreta and second had a placenta increta. The blood loss, average blood loss was 2.5 liters, and there was no maternal deaths in the series. Coming to the conclusion, among the many risk factors, the previous cesarean section is the most common. Therefore, reducing the rate of cesarean section can reduce the prevalence of the placenta accreta syndrome. Adherent placenta should be suspected in cases of previous cesarean with placenta previa, high parity, uterine curettage, and the uterine surgeries. Conservative management should be reserved for the selected patients. MRI, it is not mandatory for the diagnosis of this condition.
You said one patient underwent emergency hysterectomy, interval hysterectomy.
Yes, ma'am.
So whether methotrexate was given for
Yes,
that
ma'am. She
patient?
received the injection methotrexate
Same
one dose.
patient?
Yeah, the same patient. And then she developed a sepsis, and again we did a forced peripartum obstetrical hysterectomy.
In two patients, your conservative management was successful?
Yes, ma'am.
Out of that also, only in one patient you have given methotrexate?
Yes, ma'am.
Total how many patients you gave methotrexate?
Two patients underwent the conservative management. For
In
one
all-
patient we gave methotrexate. She underwent a peripartum obstetrical hysterectomy later, after 14 days.
After 14 days?
After 14 days. Because she developed a sepsis and she had a lot of the bleeding from the cervix.
So it was not successful in that
It was not
patient
successful.
also?
Yes.
In how many patients you could conserve the uterus?
Sorry, ma'am.
In how many patients you could conserve the uterus?
In two patients.
The cases were very nice, but I think this should have been presented as a poster and not a paper.
It's a study conducted over a period of 6 months.
No, but it could have been better if you would have presented it as a poster with photographs and all. Thank you.